Good morning, everyone. My name is Maya Luria with TMC for Seniors, and we're continuing on with our January programming. And today we're going to be talking about sleep and how sleep disorders are keeping you up. I have David Sholes here with me. He is the manager of our TMC Sleep Lab. And David, you always share such great information with us about sleep and how hopefully we can get better sleep. And so, welcome here today.
Thank you. How's
Um,
everybody
I've
today?
gone
Thank you.
ahead. I've gone
Go ahead.
ahead. I put your PowerPoint up for you. You do have an online audience, so if you're joining us from home, if you've got questions for David, please leave them in the chat, and I will ask David those questions afterwards. So I'm going to go ahead and turn it over to you, David.
Thank you. And again, thank you for inviting me to talk about sleep disorders and sleep health in general. And maybe we can have a good discussion about ways to improve your sleep and then overall awareness of how sleep impacts your general health. So I'm going to talk a little bit about sleep. There's 5 stages of sleep. The first stage of sleep is a lot like that boring part of a movie, kind of where your head drops a little bit, or maybe that not interesting part of your book. Stage 2 sleep is where you're going to spend the majority of your night. If you sleep 8-10 hours, stage 2 sleep is that well rested, established, consolidated sleep. Stage 3 and 4 sleep is what we call deep sleep. If you are a sleepwalker or a sleep talker, that occurs in this stage of sleep. Okay. Children definitely spend a majority of their time in stage 3 and 4 sleep. However, it is important for adults to have that stage of sleep. And then REM sleep. You hear a lot of REM sleep. That's dream sleep, where the only 2 muscles in your body that work during REM sleep are your eyes and your diaphragm. So there shouldn't be a lot of movement. There should be adequate breathing and ventilation during REM sleep, but that's when you're going to have your dreams. A lot of questions that I get from patients and just interested people is, I never remember my dreams. Well, you're not supposed to. If you have well established and consolidated sleep and you go through these cycles, which I'll talk about in a little bit, and you come out of REM sleep and into another stage of sleep, you won't remember necessarily the dream. The only time you remember the dream is if you woke up in the middle of the dream. For those of you that can remember a time where they had radio alarm clocks, sometimes you'd be dreaming and then that song would then play into your dream. If you've ever had that experience, that's why. Circadian rhythms. There's a lot of talk around circadian rhythms, but it's that natural cycle of when your body tells you it's time to go to bed and it's time to stay awake and be alert and be ready for activity. And so those 24-hour based day routines or cycles are very important to your patient's biological clock. So it's the hypothalamus. The brain tells you when it's time to wake and when it's time to sleep. It is possible to reverse your circadian rhythm. For those that stay up at night and sleep during the day, shift workers, people that travel over time zones, but it is important to keep that routine. Melatonin is a huge importance of the circadian rhythm, but also activity during the day also will impact your sleep at night. I like to emphasize that as you guys realize that how much activity in your normal process throughout the day will impact if it's easy to go to sleep, fall asleep, and even stay asleep. The average cycle is every 90 minutes. So like I said, you'll go through stage 1, 2, 3, 4, and 5, and then cycle through again, and then 1 and 2. The part of this discussion that I like to say is, say you have a sleep disorder or something interrupts your sleep and you're in stage 2 and you have well sleep, but then something wakes you up. You don't necessarily start back in stage 2 and then advance through the cycles. You start all the way back in stage 1. So that's where the uninterrupted part of your sleep and your sleep cycles is so emphasized. So if there's a sleep disorder say you're snoring and that's causing desaturations, or maybe apnea and that's causing you to wake, or maybe your legs, or you have a pain syndrome and that's causing you to adjust and change positions. That's that interrupted sleep that we're talking about. So another common question that I get is, how much sleep do I actually need? There is no magic number. The average patient needs about 7.5 to 9 hours of sleep. The literature supports that anybody that has shortened from there, it kind of contributes to a sleep debt, as we call it. So let's say you stayed up later than your normal bedtime, or you traveled and you went and saw somebody and then you were late to get to sleep. It will contribute to a sleep debt. And a lot of times people say, well, I'll just catch up on the weekends, I'll sleep in. You're much better off reducing or going to bed earlier by a half an hour, and paying back that debt over time, over the week, than just trying to sleep an extra 3 or 4 hours maybe on the weekends, because it's going to throw off when you go to bed the next night, and then it's just going to be a vicious cycle. Artificial sleep, another question that I get very commonly as well. I have trouble falling asleep, or I have trouble staying asleep. My physician asked me to start taking this medication, and I feel a little bit better. So the first thing that I try to say is that there's no actual sleep medication. There are medications that were put on the market and marketed for certain things and found out that it caused drowsiness. The drowsiness is a side effect to that particular medication. So any type of medication that you give to induce sleep or maintain sleep is supposed to be temporary. It's a good time to have a sleep study, whether it be a home sleep study or an in-lab study, so that we can see if there's anything underlying issues that we can address, so that you don't have to be on those medications. Just like any medication specifically around pain, as you take it, your body will get used to it, and then the side effects will deteriorate, and you'll have to take more and more of that medication to be sleepy or to be drowsy for it to work. The most popular circumstance with artificial sleep was Michael Jackson. I don't know how many of you kind of read about what was going on at the end of his life, but he was using a very heavy sedative, almost an anesthesia medication called propofol to sleep. And the bizarre behavior that he started to exhibit was because the only sleep he was getting was that artificial sleep. And so that's where, if in fact you are given some sleep medication, I'm not anti-sleep medication by any means, but if you start to notice behaviors that are bizarre, sleep eating, sleep walking, sleep talking, sleep driving is one, that you definitely bring those to the attention of your physician and say, okay, you gave me this medication, but now I've noticed these weird things. A real life example that I use, I had a really good friend that was in healthcare, and he knew that a part of my background was in sleep. And he said, David, I had something very weird happen to me the other day. And I said, well, what? And he goes, well, I went to bed. I was tired. I took my Ambien, and then I got up to go to work, and I got in the car and I saw that there was a receipt that I had went to McDonald's at 2:00 in the morning, but I don't remember going to McDonald's. And so I said, well, have you brought that to your attention of your physician? And he said, well, no, because I slept really good. I said, that's not normal. I said, you need to bring that to the attention of your physician. And he didn't listen to me. And so he had another incident where he removed all of his kitchen cabinets from his kitchen, put the new cabinets that he had already purchased that were in the extra room, put them up, put the old cabinets into his car, in his truck, disposed of them, which he does not remember where, all because of a byproduct of this medication, where it kind of created an amnesia effect, or he was asleep during this. I said, you really need to tell your doctor, I don't think that your body's agreeing with the medication that you're on. And these are very dramatic and serious, but these are real life situations that happened to him. Of course, he didn't listen to me, and the next episode, he ran his car into a telephone pole, and he got in a car accident because he was asleep. And so I tell you that point again, not to be anti-medication or anti-sleep medication. They're necessary for certain situations. They're supposed to be meant as temporary, and then for that back and forth with your practitioner or your physician. And anytime you notice some bizarre behavior, um, definitely bring it to their attention. On a smaller scale, I've heard of patients eating uncontrollably, being asleep, eating butter out of the tub, some uncharacteristic things that you wouldn't normally eat. So those are definitely some of the bizarre behavior that we're speaking about, artificial sleep. Sleep hygiene, and I'm not talking about brushing your teeth before bed. It's what you can control to try to get better sleep. If you are unfortunate, and depending on, we just diagnose you with a certain sleep disorder, that's something that's you generally out of your control. You can manage it and handle it in a certain way. But the sleep hygiene, if you don't have a sleep disorder, but you're still not happy with the way you're sleeping, these are ways that you can control certain things so that you get the best sleep possible. It's widely known that television impacts the depth of sleep, especially people that leave it on in the middle of your sleep. So you fall asleep with the TV on, and it stays on. There's that sleep mode on a lot of TVs nowadays. You can set it for 20 minutes, 30 minutes. I get a lot of feedback from patients that it's a sense of comfort, and they need to, especially if maybe they're the only one in the house. So I get that, then set the sleep mode where it turns off so it's not doing that throughout the whole 8 hours, 9 hours that you're asleep. The reason I say that is there's a waveform that happens in your brain. It's called a K complex with any auditory stimuli. And that K complex can reduce and interrupt those sleep cycles that I'm talking about. So if there's excessive amount of auditory impulses or stimulations, then it'll cause that K complex. If there's enough of them, it'll reduce that stage of sleep and the depth of the sleep, and it'll impact you. So also with the flickering of the lights, anybody who's noticed it, I've done it, where it's like, whoa, and then something wakes you up, and then you realize it's that loud action scene on the TV or that commercial that goes up 10 decibels or 20 decibels. So white noise, definitely there's a lot of literature around that it's very helpful, especially if you live on a busy street, maybe in an apartment complex or somewhere where your neighbors are unruly or late. The white noise can definitely help with that. There's machines out now that have beach sounds, wave sounds, but even a fan. And if you don't like the fan pointed on, you just point it towards the corner of the wall, and that white noise kind of drowns out some of that auditory stimulation that I was speaking about earlier. Limiting your caffeine to 3 to 4 hours prior to bedtime, as well as alcohol consumption. Definitely alcohol and caffeine can impact your sleep and your depth of sleep and the quality of your sleep. The temperature of the room can affect your sleep. It is proven that generally patients sleep better when it's cooler than when it's warmer, because you can always kind of cover up with blankets and get to that comfortable position, comfortable temperature level that you like. However, on the flip side, when you're hot, it's really hard to cool down in a sense. So make sure that you're taking that into account and setting the temperature of the room wherever you like it, so that you're able to get the best sleep possible. Control your environment as much as possible. This is the part of the presentation I like to bring up about pets. So I had a patient say, I'm not really happy with my sleep. And I said, okay, well, can you tell me about your routine or your regimen? We were talking about sleep hygiene. And he said, well, everything kind of seemed kind of straightforward. And he said, well, then the cats come to bed with me. I'm like, okay, no big deal. Because I do believe there is a huge part of comfort that will allow you to rest. Okay. But when does that comfort and those mechanisms that we have with comfort impact your sleep? Or then you may not even know it. Well, these cats would sleep on his head, on top of the pillow, on top of his head. And that's where they like to be. And so I'm listening to him, and I said, well, do you want them there? Do you want them to sleep there? And he goes, well, it bothers me, but it doesn't seem to bother them very much. And I'm like, okay. So I'm like, well, maybe, do you think that maybe that's not the most conducive for your sleep? I said, and so this is where I was like, a sleep diary would be just a little calendar, might be something that you could validate your thoughts. So maybe the cat sleep in another room for a week. You chart it on your little diary. I feel really good today. The cat slept outside. And the next week, you have the cat sleep inside. I feel really drowsy and needing to take a nap during the day. And you can validate for your own behaviors of whether or not they're impacting your sleep. Dogs, I have my best, she's now passed, but my favorite pet in the world was a 150-pound bulldog. And when she slept next to me, she took up a big part of the bed. And so even and this is what I do for a living, was like, oof, Roxy, you kind of need to go get your own bed. So, we figured it out and everything. But even I had to say, yeah, I don't sleep real well. And she snores and all that kind of stuff. So she's a great dog. So, however, if your routine involves some pets, again, I'm not saying that comfort is a good thing. It allows you to feel like you can rest, and then we'll see the sleep and byproduct. However, sometimes it can impact that, especially if you have a new puppy or a new dog that goes out quite often. We have an older dog in our household where he's constantly being let out, and my wife is like, I had to get up 6 or 7 times to let the dog out, and I feel really tired. I really don't feel like I was restful. And I said, well, why don't we leave him outside? Well, then he scratches at the door. So we're kind of and he's just kind of confused. But food for thought for that is that, that's something that you can control and something that you should probably be aware of. Naps during the day. Not saying that naps are bad. Sometimes they're necessary, especially if your routine gets disrupted, but try to limit those naps to a short period of time. It starts to worry me when patients come in and say, I take 3 or 4 hour naps. That's a long nap. And it's going to throw off your sleep onset when you go to sleep nocturnally at night. And it's going to probably delay that in all of your sleep stages in those cycles. So I would rather you limit it to 20, 30 minutes, try to feel refreshed, and then have your nocturnal or your nighttime bedtime as close to that as possible. One of the characteristics for us all, we're all aging population, to have the realistic expectation that as you age, your sleep is going to change. The one experience that I have is my dad. He never had a problem sleeping. He was in the military 35 years, never had a problem. He kept the same set routine, got up at a certain time, went to work, came home. We had dinner at the table. Everything was the same. He retired, everything out the window. He couldn't sleep. Nothing was good. So I talked to him. He knows what I do. He's like, Dave, I just can't sleep. I don't feel rested. I said, well, what time did you go to bed? He goes, well, whatever time I want. I'm retired. And I said, well, he goes, well, if mom wants to watch a show or something, we stay up a little later. He's big into books right now. He'll sleep and pet the dog, and he'll read for hours. And I said, well, Dad, probably should try to keep if that's fine, but keep a normal bedtime routines where you go to bed at the same time, you wake up at the same time. Well, finally his doctor told him the same thing. So then now he's much better, but he's honoring. So, but definitely having that realistic expectation that you probably are going to awaken in the middle of your sleep a little bit more often than you did when you were younger. You're probably going to need to maybe use the restroom a few times. That's okay. Just go to bed a little bit sooner and then maybe sleep a little bit later, and then you'll get those cycles of sleep that we talked about. I see a lot of people frustrated thinking that they're going to sleep like they did when they were younger, where they can just fall asleep at the drop of a hat, and that's where that frustration kicks in, and then they just stare at the wall and they just can't sleep. I'm a big advocate for, if you can't fall asleep 20, 30 minutes, get up, go to the front room, read a little bit. I do discourage trying to go to sleep, turn on the TV if you're going to go right back to sleep. A book, a magazine, something like that is definitely helpful. And then when you start to get dropped, then go back to bed and go to sleep. I found that helpful with my patients. This is just a histogram that kind of talks about everything I just did. Sleep latency, the time it takes you to fall asleep. WASO is an acronym for wake after sleep onset. So after you first fall asleep, how much are you awake during that time before you get up for the day? And then the stages of sleep: REM, slow wave sleep, stage 2, and sleep 1. You can see that in a lot of cases, there's a decrease in REM sleep, an increase in wake after sleep onset, a decrease in slow wave sleep, and stages 1 and 2 stay pretty much the same. That is normal as we age. We just need to be aware of it. Another histogram that talks about how many times you wake up as we start to age, and there can be a lot of contributing factors to that. I talked a little bit earlier about pain and pain management. Maybe we have some sciatica or some back trouble that's causing that. It's not necessarily a sleep disorder, but if we address some of the pain issues, then your sleep can improve. Nocturia, where you have to get up to use the bathroom quite frequently. That is something that we could address that might improve the awakenings at night and then maybe keep you in a more consolidated sleep. Something to bring to the attention of your physician if that's something that's occurring with you. That's what we talked about having a realistic expectation of your sleep patterns. Sleep efficiency is something that we coordinate at the sleep lab, where you come in and you sleep with us. We put you in bed, and then we calculate how much time you spent asleep while you were in bed, and that equates to a sleep efficiency, kind of like a report card. Obviously, 100% is really good, 90% is an A, 50% is not so good. But we'd like to keep you upwards of 75 to 80%. I think that if a sleep efficiency, if you sleep in that regimen, being in bed longer and asleep longer, that you would feel rested. Anybody under 75% generally will start to feel it. They'll start to get tired. They'll need to take naps. They'll start to say that it's impacting their quality of life, the things that make them happy. This is the portion that I get into sleep disorders. I kind of touch on the more common ones: insomnia, everything we just kind of talked about. Insomnia is a blanket term for a lot of different things going on. It's actually a symptom, not a diagnosis, but a lot of physicians are using it as such. Sleep apnea, there's two types of sleep apnea. One where there's an obstruction in your throat and your airway and allows you, so there's effort to breathe, it just can't pass. And then central sleep apnea, where your diaphragm and your brain doesn't tell your diaphragm to take those breaths in, so there's a decreased effort. We treat those two differently. However, sleep apnea as a whole is where you're not breathing, or there's a reduction in your breathing while you sleep. A lot of questions I get is, David, can I die from sleep apnea? So the way the human body is built is, if you have an apneic episode, your blood oxygen will drop and your brain will alert you to awaken, and then your airway will then become patent and open up and you'll start breathing again. So no, you wouldn't necessarily have an apneic episode and never start breathing again. However, we found that with that happening several times an hour, the normal amount of apnea in a population is under 5. So there's a certain amount of apnea that's normal, or a change in your breathing. Anything over 5 events an hour is considered abnormal. The two things we look at is, did it wake you up, and did your blood oxygen drop? With that being said, if you're going through this routine and you're having 40, 50 events an hour, it can put a big strain on your heart. And so that's what we're seeing is patients that go with untreated sleep apnea. They start to have hypertension, they start to have heart arrhythmias, and that's something that needs to be addressed. And that's generally what we see the patient's demise come from if it's untreated sleep apnea, is the cardiac issues. Periodic limb movements, where you ever feel like you need to stretch your legs or you get those creepy crawly feelings, you need to move or maybe walk across the room. That is something that is definitely hits the aging population. Um, Athletic people, active people that move their legs. The worst case of periodic limb movement I saw in a 45-year-old bicyclist. And he's just constantly moving his legs when he's awake. And then it just kind of, he developed this sleep disorder. So there's a medication that you can take that treats that so that your legs don't move and that doesn't interrupt your sleep as we talk about those cycles. Restless leg syndrome is pretty much the same syndrome, except that occurs when you're awake. Periodic limb movement happens when you're asleep. So restless leg would be that you're awake, you're fully awake, you're trying to go to sleep, but your legs are just jumping and uncomfortable and you can't sleep. So that's the only difference between those. And a very rare disorder is called REM behavior disorder. It happens more in men than it does in females, and it's usually from trauma. So we see a lot of REM behavior disorders in patients that were in war or, like I said, a traumatic experience. First responders that were buried or in a fire where they're acting out their dreams. Remember what I said earlier about the only two muscles in your body that should work for true REM sleep are your eyes and your diaphragm. Shouldn't be a lot of movement. So this REM behavior disorder is a disorder because you're now acting out. On a few patients that I studied years ago, they were veterans that came back from the war, and then they would get out of bed in the middle of their sleep study, crawl on the floor because they were acting out those dreams. So there's a medication that we can do to treat that disorder, but it is very rare, but it is something to bring to the forefront in case that's something, or, I give this talk to a lot. So if it's one of your loved ones or your family members that's maybe come to you and told you something that's happening to them, that you can speak and give them good suggestions to maybe go talk to their physician. Back to sleep disorder breathing or the sleep apnea that I talked about. This is just a diagram that tells you about the muscles in your throat. When I said that the airway becomes patent, it's open and allows that air to pass through to your lungs. And then when it occludes, you can either have big tonsils or an enlarged tongue. And then the muscles, as you relax when you sleep, they fall back and obstruct that airway. That's how sleep apnea occurs. This is a sleep study. I use this as just a visual for if you were to come in and say, I'd like to have a baseline, see where my sleep's at. This is your brainwave activity, and this is the awakening that I'm talking about. You're clicking along with sleep here. Everything looks consolidated and looks good. And then all of a sudden there's a burst of amplitude. And this is that K complex that I've talked about that it awakens you up. The reason that this K complex happened wasn't because of auditory, but was because of the breathing patterns changed here. So these arrows are from your snores. These are snoring that we monitor while you come into the sleep lab. And then the breathing patterns, nice and rhythmic here, stops, and then alerts, and then the desaturation of your blood oxygen. So it's just a good visual of what we're monitoring in the sleep lab to bring awareness, and maybe we could address that. PLMs. There's a high prevalence in Parkinson's and renal disease, diabetes, spinal disease as it is stenosis and different spinal fusions. Patients tend to have a high incidence of PLMs in those populations. REM behavior disorder, we just kind of talked about that. It definitely can be increased as you start to age. And then some of the awareness or some of the concerns that we have is motor vehicle accidents, falls, and this happens in any population. If you're sleep deprived, it can definitely impact your memory, impact your quality of life. I was talking to a patient who was in her 40s, mid 40s, and she says, David, my sleep is just really not good. And I said, okay, well, let's break it down. Have you had a sleep study before? No. She says, my friends, they want to go shopping or they want to go on a hike. And I used to enjoy doing that stuff, and I don't even have the energy to do that. And I said, well, that's the first sign that if it's impacting your daily life or the things that make you happy, then it's probably time to have a sleep study. But so people, there's like a negative stigma on having to come in for a sleep study. I try to reassure people that if it's nothing, then it just at least gives you peace of mind. And then we can work on those hygiene things that maybe clean up and that would improve the time you're asleep and whatnot. Obviously, if you don't address the sleep disorders, then you can have the hypertension that we talked about, the cardiovascular disease. It can increase your weight. Those are all contributing factors to people that are sleep deprived. They live more of a sedentary lifestyle than being more active and whatnot. Just like I said, sleep deprivation can lead to high blood pressure, stroke, diabetes. Some patients are confused by the diabetes part. If you have sleep apnea and it's almost like you're exercising because of the breathing changes, it can also make your blood sugars go up and down, and that can cause diabetes problems. So what I tell my patients is if your doctors put you on maybe hypertension medication, and now you're on 2 or 3 different ones, but never had a sleep study, maybe the problem is when you're asleep. And that's very common to have uncontrolled hypertension during the day. It's because there's actually a problem when you're asleep. So if that's something you can discuss with your physician. Same thing with your diabetes. If everything's been going really good and you've been controlling your sugars quite well, and then all of a sudden there's a change and you're struggling to keep them in those normal values, maybe a time would be to have a sleep study. And again, if there's nothing there, then it gives you peace of mind, and then you could address the diabetes or the hypertension on its own. Bedtime are kind of like little checklists that I kind of go through that kind of recaps everything that we talked about. How to get the best sleep. Is the temperature of the room okay? Are you in pain? If you are on pain medication, even if it's Tylenol, did you take it right before you went to bed so it keeps you asleep? Are you going to bed on time? If you're a positive airway pressure CPAP BiPAP user, are you using it? Is the television off? Are the pets in the room? We talked about that. Noise control. Do you want the fan? Do you want the white noise? Something of that. Did you toilet prior to bedtime if that's an issue in the middle of the night? Is the lighting reduced? Is it dark? Some people don't like it dark. I will tell you, I've been doing sleep for over 25 years now. And part of people's routine and comfort that I talked about earlier is a lot about what they're used to. I had this gentleman who told me in the question answer session, he said, David, I can't go to sleep unless I have a peanut butter and jelly sandwich. Sounds kind of silly, huh? But I was very intrigued, so I wanted to know. So I asked him about, well, how long has this been? And he goes, well, it goes all the way back to my childhood. I said, well, who made you the peanut butter and jelly sandwich? He goes, well, my mom. And I said, well, out of curiosity, does she still make it? He goes, no, I make my own now. And he goes, but it's that routine that brings him comfort, that allows him to relax. We didn't even get into whether or not his mom had passed, or if maybe she lived remotely and he didn't see her that often. But I agree, the routine is something. And I said, well, I believe it's more of a comfort thing, and that allows you to rest and whatnot. I also had another patient who said that he can only sleep if his head was facing north. So if he goes and sleeps in a hotel room, that he would always move the bed so he could sleep in this. I'm like, I don't have an answer for that, but it's very interesting. So if you yourself has noticed that, we talked about the diary earlier, that you sleep better in certain things, we're human beings. There's certain things that trigger a lot of other things. So I believe that you should continue to do the things that are healthy and that induce sleep and keep you asleep and keep you rested and comfort you, because that is a time of comfort, and try to decrease or eliminate the stuff that impacts the sleep negatively. What else? I think that's all I got. And the pets is always a big conversation, and they do bring comfort. I don't tell you that they don't, but they can also impact your sleep. Daytime. Did you wake up on time? Again, another checklist. Were you exposed to sunlight or other night light sources? That circadian rhythm is what we talked about earlier, where your brain is built, the hypothalamus is built, where there is a period of time where it's light out and you're activity driven and you're out. And then when that sunlight goes down or that light level goes down, that's where your body slows down, your metabolism slows down, the melatonin starts to be produced, and it's trying to convince you now it's time to sleep. Listen to your body. Are you active as you can be? Going out to the mailbox to get your mail, going and getting the newspaper, maybe going and having lunch with your friends. I emphasize my parents going out at least every other day, trying to do something, because their activity level has definitely decreased through the years. And so I'll call my mom and I'm like, "Where's Dad?" And she's like, "He's outside with the dog." And I'm like, "Okay, have you checked on him lately?" She goes, "He's fine, David." I said, "All right, just make sure he's okay." So I like that. And then he comes back, and then I come after work, check on him. And I'm like, "You have a good day?" And he goes, "Yeah, I did X, Y, and Z." And then he's able to lay it down and feel. I really emphasize that. Whatever it is that brings you happiness throughout your day, try to do that instead of that sedentary thing where it kind of contributes. Then it's time to go to bed, and then people can't fall asleep right away, and they get frustrated. Eliminate those naps. If you have to nap, keep them to 20, 30 minutes, and then decrease the alcohol and the caffeine right before bedtime is smart. This basically kind of covers everything we just talked over. I'll skip over that. And I think now's a good time to open it up for questions, maybe something that I covered, maybe something that I didn't, or what you'd like. Thank you, Maya.
So, yeah, thanks so much, David. So, do the changing seasons and daylight impact your sleep? I know you mentioned a little bit about the light, but what about with the seasons?
Definitely. I think people gravitate to when the sun's up later and activity driven, they stay up later, and then they definitely do feel not as rested because work still starts at the same time, or certain activities still have starting at the same time. So I think that that's a good point. They definitely want to try to keep that same bedtime for those hours in bed and that sleep efficiency, and try to get into that. Well, if the sun's still out, we can still get certain things accomplished, but it will definitely contribute negatively.
That might be harder, even like if you live in Alaska where they have, a super long, right?
Touche.
Yes. I had another question come in, and they're asking about what's a good amount of time before bedtime that you should avoid screens.
Avoid what?
Screens, as in TVs, phones.
Screens, got it. Okay. So Harvard did a really nice study on blue light, and they definitely said at least 2 hours prior to the time you want to sleep. We realized that, especially with the technology-driven society, that tablets and screens and phones are part of people's decompressed time. That's when they check their emails, whatnot. But yeah, they're saying 2 hours prior to bedtime. So try to get that accomplished earlier in the night than leaving it right before bed.
Okay, and that would include TVs as well, right?
Exactly.
Okay. What about is it ever too late to fix a sleep disorder?
Never.
Okay.
One of my most compromised patients years ago, when I was at another lab in town, was a 90-year-old grandmother, and she actually brought her husband in because she thought he was the problem. And he says, she hands him to me. She said, "Fix him. He snores too loud." And so he went to bed, and I watched him and monitored him the whole night, and he did nothing but sleep. But she was in the other room in the back, and she was kind of snoring pretty well. And so the next morning I said, "Well, have you thought about I said, "No, I think you." And so she had the study and got on CPAP and whatnot. My point being is they were much older, and we want to keep them in the quality of life that they've worked so hard to try to attain, even in their older years. And it's never too late. I would want it
now. What about another question just came in? What's the best amount of exercise and light to keep your circadian rhythm regular?
So that's probably driven by the individual, I would say. So if you're somebody that takes a 10-minute walk around the neighborhood, I would say continue to do that, but do that during the daylights. I know that's difficult when it's summertime and you try to get up. Maybe some people are walking in the dark. I see them when I'm coming to work, but that's, maybe right at the cusp when it's dawn, I would try to do the daylight then, your 20-minute walk, 10-minute walk then. So an amount is always driven by the practitioner, your physician, and you. So I don't want you to go from a sedentary lifestyle to all of a sudden walking for 2 hours. That can be dangerous. So definitely talk to your doctor. Said I talked to this guy. He's given all these suggestions about my sleep. Says I should, have more activity during daylight hours. That would improve my sleep. What do you think? And they can adjust a regimen for them.
So now tell us a little bit about the sleep lab, where you're located, how does somebody, who is appropriate to go in and have a sleep study, and just sort of what does that night look like? And has anything changed in the last, since we last spoke?
Okay. So the sleep lab is at 2100 North Rosemont, right across the campus from TMC. It's a bedroom type feel with shared bathrooms, not necessarily more of that hospital room feel. We try to keep the comfort and the bedroom feel as much as possible. However, we do have medical type equipment in those rooms to be able to treat you and keep you safe. However, not much has changed. The easiest way to get started or to be referred for a sleep study is to talk to a physician that you trust. It doesn't have to be a sleep doctor. It doesn't have to be a cardiologist. It doesn't have to be a pulmonologist. If you have a good rapport with your PCP, say, hey, I think I have a sleep problem. They can order it. You don't need to go see another doctor or see one of my doctors. Once you come in, we'll submit authorization for your insurance. When they get everything lined up, then we'll have you guys pick a date and time that works best. Obviously, it's scheduled at night, so we have people come in at 8 p.m. and 9:45, depending on their bedtime. If neither of those times work, we can accommodate you and have you come in earlier or later, depending. The rule of thumb is to try to get patients in bed trying to sleep by midnight so that we don't run out of time by the time we wake you up. And if we have to do therapy, there's certain time-driven things that we do. Probably the most recent advancement is now we can do home sleep studies. But home sleep studies have limitations. It's really only a diagnostic. If you're on the fence, if anything's going on or whatnot, we can't give you any treatment. We can't do anything. There's certain parameters that we can't monitor and certain ones that we can. So we use it like a screen. So it's a lot like a Holter monitor for your heart that you go home, you take this little computer, you put a nasal cannula on, a finger probe for your blood oxygen, a belt that monitors your breathing and effort, and then go to sleep. And then we download the data and we can tell, hey, this is what, and then you will probably end up having to come in to the lab for a study if it's positive. If it's negative, then your doctor may choose to just stop right there and do the hygiene things, maybe do some things that they can control. That's really the advancements right now. There is the, I'm trying to think of the name right now, but it stimulates the back of your palate if people don't want to do PAP therapy or CPAP or bilevel. And then there's the mandibular advancement where your dentist can fit you with a mouthpiece that pulls your mandibular forward. And for patients that have sleep apnea, it can eliminate that without the need for PAP therapy. Those are the two advancements over the last few years, 5-10 years, that we now are able to get in the mix. Some patients, it's possible, and some patients still need to have the traditional therapy.
And is it typically, it's referral based, obviously, and the phone number that they call?
520-324-3318.
Okay, perfect. I'm going to go ahead and put that up on the screen here as well for folks if they've got more questions regarding the sleep lab. Does Medicare cover sleep studies, or how? I'm not sure what's covered on that.
Good question. Yes, Medicare definitely is a big advocate for getting you treated and getting you treated as early as possible. So it's covered by Medicare, both parts A and B. And the only stipulation that Medicare has is there's a limitation by how many sleep studies you can have in one calendar year. So the most you can have is 3, which is not uncommon. If somebody comes in and they're not really exhibiting a lot of symptoms, but they're just not right, they have a home sleep study, then they come in, and then they have an in-lab study, but they didn't qualify for treatment until late, and then they have a treatment study. That's the 3 studies. So they try to keep us under that. So my staff know that. We try to keep it so there's not an expense passed on to the patient.
Great. Okay. Well, perfect. That was all the questions that I have that have come in from online. I want to thank you so much for being here. I'm going to turn it over to you to answer any questions from our in-person audience, and I'll wrap up here. Thank you. Thanks again for being here today. We will be back online next week on Tuesday, January 23rd at 10 a.m. for Fraud Alert, Scams Targeting Older Adults with the Division of Aging and Adult Services. Please give us a call at 520-324-1960 if you are interested in attending that class. Have a great day.